Bismillah ar-Rahman ar-Rahim. Good day, everyone. I'm Dr. Mahmoud al-Sheikh, a nephrology learner. Today, I'm presenting a lecture based on a new article from C. Jason, focusing on how to treat glomerulonephritis in elderly patients. This is a tailored approach, revisiting geriatric GN and customizing care when one size doesn't fit all. Especially when we are dealing with medications in frail or elderly patients, it's crucial to remember that older adults are a particularly vulnerable group. So always keep these principles in mind. First, that the dose makes the poison. And second, to always don't do harm. It's not just about reaching a diagnosis or providing treatment, but ensuring that our patients remain safe throughout their care. Starting our case today, 89-year-old male with well-controlled hypertension on amlodipine and history of colon cancer, presence with nephrotic syndrome. He has mild neurobehavior slowing and can only do light housework. The physical examination shows blood pressure 140/100 and 2+ bilateral leg edema. Labs revealed normal renal functions, and urine analysis revealed 3+ protein and no blood in urine, urine PCR of 7.8, serum albumin 2.4, and anti-pilar 205. So what's your next move? When we are dealing with frail elderly patients who present with glomerulonephritis, it's essential to keep their vulnerability in mind throughout the entire process of diagnosis and evaluation. In older adults, age-related physiological changes can complicate the diagnosis of GDs, glomerulonephritis, and diseases. Common comorbidities like hypertension, diabetes, and atherosclerosis may contribute to kidney issues. In addition, polypharmacy increase the risk of nephrotoxicity and drug-drug interactions, while cognitive impairment and frailty can hinder adherence to treatment. Evaluating older adults with albuminuria can facilitate early detection and potential treatment of underlying conditions, helping to mitigate these associated risks. It's important to keep in mind that this frailty is a cornerstone of our decision-making process, guiding us to carefully balancing the risk and benefit throughout the entire management plan. Frailty is an evolving concept describing vulnerability to adverse outcomes, plays a key role in managing glomerulonephritis in this patient population. The adverse effects of immunosuppression drugs used in glomerular disease stem from their mechanism and necessitates careful risk-benefit balance, particularly in older adults defined as those 65+ years. Advanced age and baseline frailty scores are independently linked to higher mortality and adverse events with longer hospital stays. Balancing this disease control with treatment toxicity is essential in such group. Frailty encompasses somatic, functional, and neurobehavioral, nutritional, psychological domains with various tools available for assessment. The big question now is whether or not to perform a biopsy in these patients. This is a common debate in nephrology, especially when dealing with such vulnerable groups. In the absence of non-invasive biomarkers, kidney biopsy remains the gold standard for diagnosis of any glomerulonephritis, even in older adults. This is a rule. The benefits of histopathological diagnosis often more than the risk, enabling tailored immunosuppressive therapy. This is crucial in this age group where treatment efficacy and adverse effects must be carefully balanced. Novel antibodies such as antiphospholipase A2 receptors and antinephrin may reduce the need for biopsies, particularly in frail older patients. Despite concern about invasiveness, study shows that kidney biopsy is feasible and safe in older adults with appropriate precautions, yielding similar complication rates as in younger population. The clinical frailty score will help guide our approach both in terms of diagnostic steps and management strategies for this frail patient group with a cut point of 5, and we will explain that. Frail individuals are more prone to infections, organ dysfunction, poor drug tolerance, and as we mentioned before, drug-drug interactions. Frailty scores support personalized treatment decisions, helping determine whether to pursue aggressive or conservative therapy to optimize outcomes and reduce the harm. Okay, what about the frailty score, CFS score? It is for 9 levels. Level 1 to 3, degree of fitness prior to risks associated with frailty. Level 4, very mild frailty, described as slowing difficulty with heavy housework. Level 5, mild frailty, described as changes in function and dependence on demanding activities, and this is a cut point for decision-making regarding diagnostic modalities and treatment options. Level 6, moderate frailty. Level 7, severe frailty, and level 8 to 9 degrees of frailty approaching the end of life. Essentially, these are the general principles for managing any group of patients with glomerulonephritis, regardless of age. However, we will now highlight some specific considerations that deserve special attention. Supportive care targeting bone disease like calcium and vitamin D and all others, thromboembolism prophylaxis, cardiovascular risk control like diet and LDL control, glomerular hypertension control like RAS inhibitors is very, very crucial in such group. SGLT inhibitor show promise in proteinuric non-diabetic patients, although their role during active glomerular disease and immunosuppression remains unclear. Although the authors suggest consideration of these medications for glomerular disease with elevated proteinuria, there is, as we know, all limited evidence to just suggest benefit in active GD other than IgE nephropathy. Thus, treatment may need to be individualized at this time till further evidence in support of their use is available in other active GDs. Treatment should be adjusted based on kidney, liver function with close attention to infection risk. In frail patients, the risk of immunosuppression may outweigh the benefits, although no elderly-specific GD guidelines exist. Lab monitoring frequency should reflect frailty, with monthly lab results or home blood draws, improving follow-up in frail patients. Older patients with GD face high short mortality on short term, and they require careful balance between effective and safe immunosuppression. For example, in ANCA-associated vasculitis, first-year mortality is 5 times higher, especially in older adults and those with kidney impairment. Immunosuppressive agents improve survival but are often underused in frail patients. Trials such as low-dose steroids plus rituximab versus high-dose steroids plus rituximab for remission induction in ANCA-associated vasculitis showed that reduced dose of steroids can lower serious side effects without sacrificing the efficacy. A novel steroid-free regimen combining steroid rituximab or low-dose cyclophosphamide showed promising safety and remission in very elderly patients. These findings underscore the need for individualized, again, although often non-evidence-based or weak evidence, treatment strategies to balance efficacy and safety. For certain specific conditions clearly mentioned in the article, we will not delve into the difference in managing elderly versus younger adults, as that would be quite time-consuming. Instead, we will focus on highlighting the important diagnostic consideration, ensuring safe management for this particular group, starting with FSGS. Diagnostic consideration to be in mind, whatever the CFS score below 5 or equal or more than 5, kidney biopsy, if feasible, is the rule. Biopsy may help differentiate between primary and secondary FSGS. By the degree of effacement, extensive or diffuse in primary and mild to moderate in secondary causes. This also beside the clinical scenario, serum albumin, serum markers, and the scenario of patient, age onset, and all of these. FSGS lesion is often secondary to malignancy, monoclonal gammopathy, and infection or medication. In such age group, just keep in mind all the time malignancy and monoclonal gammopathy if you are facing FSGS in elderly. What about primary FSGS? Suggested treatment approach: if CFS score below 5, oral prednisolone tablet starting from 1 mg per kg, maximum 6 mg, for at least 4 weeks, and until complete remission is achieved for a maximum 12 weeks, whichever is earlier, and then taper by 10 mg per week until 20 mg, followed by 5 mg per week decrements. Consider individualizing the taper regimen for per clinician discretion. For steroid-dependent or resistant patients, cyclophosphamide or cyclophosphamide may be used cautiously. Rituximab, the steroid-sparing favorable side effects medication, 1 gram, 2 doses, 2 weeks apart, with the target CD19 below 1%. What if the CFS score is equal or more than 5? Consider rituximab versus conservative management. But for immune-mediated FSGS, consider immunosuppression, although response is less predictable in elderly. Okay, when considering minimally changed disease, if we look at this diagram from the previous Neph Madness conference, which outlines the etiology of nephrotic syndrome by age, we can see that in earlier age, minimally changed disease is the most prominent cause. Its prevalence decreases over time, and we start to see conditions like FSGS and membranous nephropathy emerge. Notably, the prevalence of membranous nephropathy remains relatively stable over time, but begins to decline around the age of 60 or older. What about treatment? Treatment would be very similar to primary FSGS. For the rare potential minimally changed disease, as we mentioned in the age group 60 plus, rule out lymphomas or other malignancies or other secondary causes, especially simply non-steroidal intake. Most common cases I face minimally changed disease on elderly was due to non-steroidals. But as we mentioned in FSGS, keep in mind malignancies, lymphomas in your mind. Okay, what about anti-GBM disease? Starting with diagnostic criteria, FCFS score below 5 usually diagnosed via anti-GBM antibodies and the severity of AKI. The need of biopsy at this stage will define the chronicity and the need to continue on immunosuppression or to omit it. But if the CFS score is equal or above 5, biopsy can be skipped. If no significant fibrosis, no pulmonary symptoms, avoid treatment in such stage. What about treatment modalities? If CFS score below 5, intensive therapy is often required. This is emergency. High-dose steroids, cumulative induction of 1.5 to 3 grams over 3 days, followed by 1 milligram per kg oral steroids, or oral cyclophosphamide, 25% dose reduction in elderly is a very important tip. a dose of 2 milligram per kilogram per day versus IV cyclophosphamide. And notice that authors of this article tried both IV cyclophosphamide and oral. Plex minimum of 7 to 10 exchanges. Retox has limited data but could be considered in resistant disease. And if the patient is dialysis dependent after 3 months of therapy, switch to conservative management. What about CF score equal or more than 5? Treatment similar to FS score below 5, consider lowering steroid dosing, and may consider lower IV cyclophosphamide dose because of the low cumulative and side effect profile in comparison to the oral. Consider up to 7 Plex sessions. Jumping to IgA nephropathy. Diagnostic consideration kidney biopsy typically required for prognostication, MIST score, the mesangial hypercellularity, endocapillary proliferation, segmental sclerosis, and tubular interstitial score involving crescent in the scoring system. You should rule out infection-related GN because it has different nature from the simple primary IgA nephropathy. Suggested treatment approach: if CF score below 5, if chronicity, you should follow foundational therapies with RAS inhibitors, SGLT2 inhibitor, endothelin antagonists. If active endocapillary proliferation, steroid-sparing agents like target release budesonide, MMF in selected population, complement inhibitors like iptacopan, the oral factor B inhibitor, which show reduced proteinuria and stabilize renal function in C3 in potentially disease modifying agents. This, I think, in phase 3 trial still. As also all we know that eculizumab, the anti-C5, is still the most commonly used complement blocker, this IV form, though it's off-label in C3G nephropathy also. Steroids for severe cases with no major contraindications, a dose of 0.5 milligram per kilogram per day for a total of 6 months with infection prophylaxis, and this is a very important tip. CF score more than 5, we should follow conservative protocol. What about membranous nephropathy? For diagnostic consideration, if CF is below 5, kidney biopsy is recommended, especially if anti-pilar negative or reduced kidney function. And for staging, we should also rule out malignancy-associated membranous. If CF score more than 5, skip biopsy, rely on serological markers like anti-pilar for diagnosis and monitoring. Rule out also malignancy-associated membranous. What about the treatment options? If CF score below 5, based on risk of progressive loss of kidney function, baseline estimated GFR, degree of proteinuria, hypoalbuminemia, life-threatening nephrotic syndrome. If mild risk, follow conservative management, continuous observation for up to 6 months before considering immunosuppressive therapy. If moderate risk, consider treatment with lower risk immunosuppression such as rituximab. If high risk, treat with rituximab 1 gram IV 2 doses 2 weeks apart, or rituximab 375 milligram per millimeter square for 4 weeks doses, for weekly doses. If very high risk, consider cyclophosphamide and steroids. But if the CF score more than 5, depending on cognitive physical frailty, decide on pure conservative management versus rituximab treatment. Going to ANCA-associated vasculitis. Diagnostic consideration. If CFS score below 5, given the high mortality, kidney biopsy is essential, especially with negative serology to rule out the important entity ANCA-negative vasculitis. If CF score more than 5, same also, kidney biopsy is very essential. But if serology MPO PR3 strongly supports diagnosis, start treatment without biopsy. to skip biopsy at that time. Suggested treatment approaches: if CFS score below 5, low-dose steroids, cumulative induction of 0.75 to 1.5 gram over 3 days, followed by 0.5 milligram per kilogram oral dose, and tablet by week 12 to 5 mg dose. Early use of steroid-sparing agents like avacopan, plus standard immunosuppression as below. If serology MPO PR3 strongly support diagnosis, start treatment without biopsy. Can follow the standard immunosuppression protocol with close monitoring, rituximab protocol in most. Mild cases, rituximab, cyclophosphamide or combination. Severe cases, cyclophosphamide, rituximab or cyclophosphamide alone. Plasma exchange, reserved for lung involvement, severe EGI without chronicity on biopsy or with concomitant anti-GBM disease. For maintenance, rituximab or AZA at a target dose of 1.5 to 2 milligram per kilogram per day, with or without steroids and avacopan. If CF score more than 5, rituximab-based regimen, maintenance, rituximab is also preferred. Okay, what about C3 glomerulopathy? Diagnostic consideration: kidney biopsy is very essential. Rule out 3 monoclonal gammopathies and infection-related GN, and also you should order full complement panel. Suggested treatment approach: if CFS below 5, consider oral anti-complement agents or MMF at 2 to 3 grams per day as tolerated. Oral complement like we mentioned, iptacopan, the oral factor B inhibitor. If CF score more than 5, conservative management or low-dose MMF if tolerated. So if CF score below 5, we have two choices: oral anticomplement if available, or MMF 2 to 3 grams per day as tolerated. But if more than 5 or equal, conservative management, or you can choose low-dose MMF if the patient tolerated. Back to our case, this patient has CFS score of 5 according to the data available. After risk-benefit discussion with him, shared decision-making, he opted to skip kidney biopsy. Rituximab was used to treat his membranous nephropathy, resulting in clinical remission without any side effects. Finally, from the reflection in this CJSN article, it's important to note that many studies on glomerulonephritis and elderly come with limited evidence, often due to lack of long-term follow-up and the higher mortality rates within these study groups. Therefore, it's crucial to keep these factors in mind and, as mentioned before, adopt an individualized approach that carefully weighs the risk and benefits for each patient. Thank you so much. Goodbye. See you in the next lecture, inshallah.